Hi, I'm Dr. Isham, and today we're going to talk about the peripheral arterial disease. So, peripheral arterial disease is actually the atherosclerosis of the extremities. Virtually, it's always the lower limbs that results in ischemia. So, what happens is that because of this atherosclerosis, there's a narrowing of the blood vessels supplying to your legs, and it produces the certain symptoms. So, it could be either a mild one, the mild peripheral arterial disease, or it could be severe one. So if we talk about the symptoms here, so the symptoms here for the mild peripheral arterial disease, it could be asymptomatic, or it can cause intermittent claudication. Okay, while the severe one, that causes pain in the rest, right? Rest pain, and because the blood supply to that extremity is mostly it's the lower extremities, it's reduced significantly in severe peripheral arterial disease. So there are the other changes as well, like skin atrophy, hair loss, and there could be cyanosis, and eventually could lead to ulcers if it's very critically compromised, and the gangrene. So it depends on the degree of the atherosclerosis. So it could produce the mild symptoms if it's less. So it could be either asymptomatic or intermittent claudication. And with the severe one, it could cause pain in the rest and the rest of the things like skin atrophy, cyanosis, gangrene, and the ulcer. Another very important thing is that this atherosclerosis, it's a systemic disorder. So almost 50 to 70% of the patients who are having this peripheral arterial disease, they have significant coronary artery disease as well, because it's a systemic disorder. It's not only limited to your legs of the patient. So it does involve the coronary artery disease, coronary arteries leading to coronary artery disease, and the cerebrovascular disease as well. However, this coronary artery disease that could be silent in these patients who are having peripheral arterial disease. And why is that? Because this peripheral arterial disease that leads to the claudication and the symptoms, the pain when the patient is walking. So it prevents the patients actually from exertion. So if they are not exerting, so they are not getting the chest pain, and it does, if they are not exerting, so they don't exert enough to produce the typical anginal symptoms. So because of their limited mobility, you can say, because of they are getting this leg pain, okay, claudication, so they are not mobilizing like a normal person. So their mobility, their exertion is limited. So if they are not exerting, they're not producing the anginal symptoms. So that's why this coronary artery disease, particularly, that is silent in them. So they do have underlying significant coronary artery disease, but they are not symptomatic because they are not exerting that much because of having the pain in the legs. That's what we call the claudication. Next is let's talk about the risk factors for peripheral arterial disease. There are so many: cigarette smoking, diabetes, hypertension, um, increased age. Males have a more risk of having this peripheral arterial disease than females. Then obesity, then dyslipidemias, and if someone is having family history of atherosclerosis. And another thing is that is high homocysteine level in the blood. So these are actually the risk factors. Okay, let's talk about the symptoms. So as we said earlier that the patients are having intermittent claudication. So what happens is that They have painful, aching, cramping, and uncomfortable sensation in the legs that occur during the walking. So pain in legs actually, and it is relieved on rest. So that's a very typical symptom. It usually most of the times it occurs in the calves, but can also occur in the feet, thigh, hips, buttocks. Um, and as the peripheral arterial disease progresses, what happens is that the distance they can walk without the symptoms that may decrease. This means that as it progresses, so they are getting the pain on a lesser distance they cover as compared to what they used to cover previously. And if it's a severe PAD, peripheral arterial disease, so the patients can have pain on rest as well. So what are the symptoms that as the patient is walking, so he's having the pain, and it's relieved by the rest. But in the severe cases, they have the pain on the rest as well. This rest pain, this actually it aggravates by leg elevation, and it lessens when the legs are below the heart. Mild PAD can produce no symptoms, as we discussed earlier, and the severe PAD that produces even the pain on the rest as well. If we talk about the signs, um, let's talk about the signs. So mild PAD, there will be no signs. Okay, and moderate to severe PAD, that causes diminished or absent peripheral peripheral pulses like popliteal, tibialis posterior, or the dorsalis pedis. Diminished or absent pulses. Uh, so it's going to be in the moderate, it's going to be diminished. In severe, it can be absent pulses in the legs like popliteal, posterior tibial, and the dorsalis pedis. And the other sign you can look for, particularly in moderate to severe, is like thinning of the hair or the hair loss. Distal legs and the feet may feel cold, and yeah, the affected leg where there is severe peripheral arterial disease that sweats excessively, and it might be cyanotic. Probably this is because of the sympathetic nerve overactivity. Okay, let's talk about the diagnosis. So, as you can diagnose this thing, you can suspect the peripheral arterial disease with the history, as we said, and the examination. Then there are the certain things you can do is ankle brachial index. Then there is ultrasonography, that is Doppler, and then angiography as well. This is peripheral angio. So in ankle brachial index, so it's actually the ratio of ankle systolic BP to the arm systolic BP, and we get a certain value of that one in the numbers. So if it's mild, if the value is between 0.1 to 0.9, it's mild. In moderate, it is 0.41 to 0.7, and in severe, it is less than 0.40, less than or equal to 0.40. And anything that is between the 0.91, sorry, because 0.71 to 0.9 is mild. So anything between 0.1 to 1.30, that is normal. So it's a normal index. But if the suspicion of the peripheral arterial disease remains high in a patient on the history and the examination, but the ABI that falls in between 0.91 to 1.3, that is completely normal. In these patients, this index, ABI index, is determined after the exercise stress test. So there you need to make these patients exercise and then do this ankle brachial index. So this is ankle brachial index. There is another thing that is called transcutaneous oximetry, TCO2. So this peripheral arterial insufficiency can also be assessed by this method. So this TCO2 level that is less than 40 mmHg is predictive of poor healing, and a value less than 20 mmHg is consistent with critical limb ischemia. So it is actually a tool for the assessment of peripheral arterial insufficiency. Okay, so this was ABI, ankle brachial index. The other thing is, as we discuss, is the second one, that is Doppler, and the third thing is CT peripheral angio. So that's gonna give you a visual evidence of the peripheral arterial disease. Next is that if we talk about the treatment of peripheral arterial disease, the first thing comes is that is important is risk factor modification. I hope you remember the risk factors. That was diabetes, hypertension, hyperlipidemia, then certain other things, which were the there are certain non-modifiable risk factors as well, like if someone is male or increasing age, but the hypertension, diabetes, cigarette smoking, that's important. Dyslipidemias, obesity, that is, these are the modifiable risk factors. So risk factor modification, that is most important. The other thing is, okay, the second is exercise, that is important here. The third thing is and the medications we are having, so antiplatelets, pentoxifylline or cilostazol. These are for claudication, sometimes pentoxifylline and cilostazol, then ACE inhibitors, and then we have the peripheral angioplasty and the surgery. That's another option. So first thing, modify risk factor modification, and yeah, the exercise comes in risk factor modification. The second thing we would discuss is, that's also one. The second thing, if we discuss, okay, let's move here, that is antiplatelets. Okay, so normally aspirin, 75 to 325 mg once a day, or the clopidogrel, that is 75 mg per day. That's helpful. There are some studies that along with the aspirin 100 mg, if we give rivaroxaban, that is an drug, 2.5 mg BD. So this actually reduces the incidence of cardiovascular mortality in the patients with peripheral arterial disease, because as I said earlier, peripheral arterial disease is not only in the legs; it's a diffuse process. The most of the patients, 50 to 75%, they do have the coronary arteries involvement. So aspirin 100 along with the rivaroxaban 2.5, it reduces the risk of the cardiovascular morbidity, but definitely we're combining the both, so there is increased risk of bleeding. So aspirin 75 to 25 mg or clopidogrel, that's the one option, and the other one is aspirin plus rivaroxaban. The next medication is, so first the modifiable, the risk factors modification, second antiplatelets, and yeah, we discussed about the DWAC as well, that is rivaroxaban. The third thing here is the drugs which help with the claudication, that's pentoxifylline. The dose is 400 mg TDS, or the other one is cilostazol, that is 100 mg BD. So these help with the claudication. These medications, they can't be a substitute for risk factor modification and exercise. So they do help with the claudication, but you can't substitute with the exercise and risk factor modification. That is more important than using these drugs. Then there are the other drugs as well, like um, L-arginine, nitric oxide, and vascular endothelial growth factors that might help with decreasing the pain in peripheral arterial disease. That can help with the claudication. Okay, let's move towards the other things, that is PTA. So first, risk factor modification, we discuss antiplatelets, then certain other drugs, pentoxifylline and all that. Now we are moving towards the intervention. So this is percutaneous transluminal angioplasty. So this is for someone who is having a pain in the rest. Definitely someone who is having a severe PAD will be having a pain at the rest, or someone who is having gangrene. So you can go for this thing, that is PTA, percutaneous transluminal angioplasty. It's a method of actually non-surgical method of dilating vascular occlusions and putting the stents in. But this is not useful for the diffuse disease. Long occlusions are eccentric calcified plaques. And the last thing is to go for the surgery. We do have many options here, like thromboendarterectomy, which is the surgical removal of an occlusive lesion, then revascularization, like bypass, femoral bypass grafting, femoral popliteal. That's one example. The other thing, you can go for sympathectomy. It's effective in the patients who cannot undergo actually the major vascular surgery, and as a last resort, one can go for amputation. It is indicated as a last resort for uncontrolled infection, unrelenting pain, and progressive gangrene. Okay, let's summarize this one. So this peripheral arterial disease is almost always in the lower extremities. 50 to 70 percent of the patient, they have coronary artery disease related with the or the cerebrovascular disease that is related with this peripheral arterial disease. The next thing is that peripheral arterial disease causes intermittent claudication, which is a discomfort when you are walking and is relieved by rest. But the severe peripheral arterial disease can present as rest pain. Okay, then the diagnosis was okay with the history, with the examination, the test we do, ankle brachial index. So anything that is less than 0.90 indicates PAD, and we divide it into mild, moderate, and severe. In the treatment, if we come, so modify the risk factors, give antiplatelets, you can try statin. Then we discussed a little bit about the DOAC as well. Then the medications which can help with the claudication symptoms with the pain, that's pentoxifylline and cilostazole. And lastly, we discussed about PTA, percutaneous transluminal angioplasty, with or without a stent insertion, and as a last resort, the surgery, surgery, and as a last resort, amputation with its gangrene.